video clips. So we'll do an intrasulcular incision on the teeth adjacent to the implant first and work toward the implant. This implant crown is not really over-conjured, but it's over-conjured relative to the implant, so it's difficult to dissect that facially. So the best way to do it is to mobilize all the tissue lateral to it and then work toward it. Once again, it would have been easier, maybe more successful, if I had used an access incision. So let me ask you, where would you make the access incision? And what kind? The two options are papillary incision or submarginal vertical. Which would you do? And where? So we have an implant here, so we're not going to involve these papillae. And this is a pretty thick tissue over the central, so let's go posteriorly, which is more desirable anyway. So I think the ideal location is here, at this, either this papilla or a submarginal vertical here. Because there are porcelain crowns, I would not do a papillary incision because we might expose the margin. So I would do a submarginal vertical here, well away from the gentle margins. I'd like you also to note that when I'm doing this blunt dissection, I cannot fulcrum off of the crowns because I might break them. So I'm having to fulcrum off of my finger and protect the crowns. What I'm doing here is attempting to dissect with the end-cutting intrasulcular knife because it is thinner than the elevator. I'm trying not to break that little bridge of tissue. So I've worked lateral to it, and now I'm trying to go through the sulcus and manage that tissue, and you can see I was not successful. I broke that little bridge. I think that had I used a submarginal vertical, I might have avoided that little break. I don't know that it would have mattered in the outcome, but I think it's better technique. Here you notice I'm fulcruming off my finger, so I don't put pressure on the porcelain margins. So there's a lot of bound down gingiva to dissect. It takes a while to do it. You have to be cautious because of the crowns and to avoid perforations, and you encounter the irregularities where the bone loss is around the implant. You encounter the threads. Sometimes you encounter some non-resorbed, slow resorbing bone particles you may be familiar with. So it is much more difficult than treating teeth. So the last prep here, major part of the prep, is a sharp dissection with a modified Orban knife. I did not have the arrowhead knife at this time, so I would start with it normally, but I'm using the modified Orban knife, and the disadvantage is, you see how close I'm coming to the margin with the sharp edge of that instrument. You could easily injure it, but just really careful application, and you can do the sharp dissection and not harm the margins. And I'm mainly doing this sharp dissection to make room for the graft, because I'm not moving this coronally, so I don't need to relieve tension for coronal advancement, but I do need space for the graft. And I want to put in a graft that has an 8 millimeter of vertical dimension. So the dissection is primarily to make space and make sure there is a complete passage of the graft without interference from any little fiber attachments that I missed with the blunt dissection. So we continue that dissection. I'm just freeing the papilla from the facial aspect. I'm not taking it from the crest because it's an implant, and that's, I think, risky. And now we're ready to insert the graft. And this is the graft on the surface. It's a bit thick. This is an alloderm graft. And this is the basement membrane on the surface. And I'm going to compress it with the side of the curette to insert it through the sulcus of the lateral incisor. So the challenge here is to insert this in a sulcus with a papilla that's adjacent to the implant. So again, the wiser thing to do would have been to have used a submarginal vertical. But I was able to work that into this area, so I can compress it a little bit and work it in. This is Shannon's curette over here, comes into view every now and then. It's on her finger. She's trying to protect that graft from falling out of the mouth. It's not good. Catch it before it hits the tongue or worse, the floor. It's hard to use it. In this case, it's not too bad because it's out of a package. We could just trim another one and soak it and continue. If it's a palatal graft, and you drop it on the tongue, that's really not good. You drop it on the floor, it's worse. I have a colleague whose assistant caught it in a large aspirator and went right down the tip of the aspirator. That's not a good feeling. I think you know the person I'm talking about. And then you have to harvest again. It's less painful to harvest from a package and then from the pallet. So that graft wants to turn vertically during the insertion, that's okay. And again, that's Shannon's finger. It's edited a little bit. It took a little bit longer than you're watching. And then I'm turning it to position it, guiding it with my finger as well. Turned it horizontally. And just slowly work it so there's no tension on that patella. Just don't be in a hurry. And now it's inserted. Compress it a bit. Push the margin so it's well adapted to the level of the what would be the CEJ, the crown margins. And now we suture. Here the suture position is not critical because we're not advancing it coronally, and we're not having to close the size papillae, so you have a lot of options about penetration placement. So penetrating about 4 millimeters off the margin, pass the needle through the embrasure. Shannon captures it, passes it back to the facial. And I catch that needle, and then I'll go under this patella to get to the distal of the implant. And I'll exit through the little defect here. It makes it a little easier to get the needle. So you may as well use it. I mean, there's a little problem there. And there's no issue. But when you suture, you want to not have the suture lie into that defect. You want it beside it. So we're going to penetrate lateral to it, about 4 millimeters off the margin. And exit through the sulcus. And then simply go through the embrasure around to the facial, engage tissue at the mesial, 4 millimeters off the margin. And waiting patiently for that needle to come back. And there it is. And we draw that suture in gently, make sure that's not lying at the defect. Now penetrate at the mesial of the implant, 4 millimeters apical to the margin, penetrating the overlying tissue and the graft. Bring the needle out, make sure that suture doesn't lie in the defect. Go around the implant, under the patella, get the mesial of the lateral incisor, come back around, and tie. So this gets edited down a little bit. We have the tie in place, and it's finished surgery. And then this is a sutured view at the end of surgery and a 24-hour appearance. So you can see there's little damage to the tissue in that time frame. And pre-op in 15 months. So this was successful in augmenting that defect and preventing a worse problem. If this is left alone and untreated, it's going to lead to a major redo. But what we use, and just for purpose of demonstration, I'm going to come through the patient's throat. I would advise that you not do that. So in order to not do it, I'd have to use my left hand. But if I were treating a real patient, I would be in a completely different position, and I can't do that from this video. So you want to detach the tissue by entering the sulcus. And the way you do it, let me see if I can show you better from this angle. You want to come in with the instrument, so the tip of the blade is touching the root, and just glide down till you hit bone. So you just slide down that root surface. You don't come in parallel to it, but you come in at an angle and glide down that root till you hit bone. And then you'll just do that and walk that instrument around the tooth, and you're just separating that
2 millimeters of attachment from the facial aspect of each tooth, including the second molar. We're not treating it, but we need to mobilize it. And it's just a matter of walking it around, pressing till you hit bone. Normally that's about 2 millimeters. Here it's a little deeper, so there's an osseous dehiscence. And we'll include this premolar. And once you have the facial part done, you can do the proximals. And since I'm treating these two teeth, I need to eventually separate the papilla between the two premolars, and between the premolar and the molar, and between the molars. So I have to detach the papilla from the proximals at each of those papillae that I will separate. So you want to go all the way over to the lingual surface and join the section that you did facially. Can you see that okay? And then I need to include the papilla between the molars. So I have to go all the way to the lingual line angle. So what you're trying to do is to attach the soft tissue attachment to the proximal of each tooth so that you can later separate that papilla from the crest. But right now I have to attach it from the tooth proximally. Now I need to do elevation, blunt elevation. I'll turn this to give you this view with the curved end of the elevator. So if you can see that curved end, and if you insert it so that the curve is parallel to the root and then rock back, you can start to dissect that tissue without distending the margin. If you did it with the curve facing downward, you'd have to push the margin out of the way to get to the tissue. So you're pushing it out of the way if you do it that way. So what I'm doing instead is coming in with the handle at an oblique angle, but the blade, the curved blade, parallel to the root surface. And then just rock back, and I'll dissect under the papillae. I need to dissect this site at the second molar, do the premolar. I'm just doing a partial dissection here at first, and the first premolar. And what I mean by that, I'm not going 8 millimeters on every single tooth to start with. I want to mobilize the tissue gradually, because that way you don't put too much tension on the papillae or on thin tissue. So just be aware of tension to the tissue, be delicate. I do this with a light touch. You could go completely under the papilla between the teeth, to elevate it. Let me see the posterior elevator, please. I want to show you about the posterior elevator. I'll have to use my left hand to use it correctly. You wouldn't in the mouth, but I mean, I would be in a different position. So this instrument is useful for dislodging the distal aspect of a papilla. So that's at the mesial of this molar, for example, because it's a posterior area. I can come into the mouth from the front of the patients, from the mouth toward that site, and I can engage that tissue and then just glide along the bone to detach that distal aspect of the papilla. So I'm underneath the tissue doing this. On the surface, it'd be like this. That kind of movement. Don't pick at it, because that will perforate it. Sometimes I'll use that on more anterior sites. This instrument has more limited use than the straight elevator, but it is often very helpful in the dissection process. So it's an essential instrument in the kit. I need to extend the blunt dissection now that I've done initial blunt dissection. So I want to extend this about 8 millimeters at every site, under the papillae as well. So I'll start to get good mobilization. And once I've done that, I can either do sharp dissection now, or I can elevate the papilla. It's immaterial, but you don't elevate the papilla till you reach this point. But I can do sharp now. Let's do sharp next. And the reason I'm doing this next is what you want to think, and again, I've said it a few times, don't think blunt, sharp. Think hard contact with the bone for initial dissections, change instruments, and think light contact with the bone, or maintain contact with the bone. It really, it's staying in touch with the bone is the secret. So with this instrument, you see it looks like an arrowhead. I can see if you have a better view of it here. Can't tell where you can see it better. Once I drop a little bit under the margin, now that shank, the dull shank, is contacting the marginal tissue, so I can engage closer to the gingival border without cutting anything. So I just course along, and you can feel the irregular contacts, or I'm sorry, you can feel the irregularities of the bony surface with a small blade like this, so you can negotiate some of the little dips and rises in the bone. So I do the initial dissection at each tooth. I need to include tooth past the one I'm treating. We have to have this mobile as well. So at each end, I'll do the sharp dissection. And I want this to be about another 7 millimeters in this model. In case of the model, that's going to be near the base of the model. So you need to free that tissue all the way at the base, or it won't advance. In the mouth, that's about 15 millimeters. There's no base of the model in the mouth, but the distance is about the same. So if you'll notice this, if you see the bend of the shank is pretty near the level of the CEJ, and you're pretty near the 15 millimeters. So that's the guideline you can use. So if this were a lower premolar, you drop in, and once you get to the bend of the shank where there's recession, don't use the gingival margin, but the CEJ, once you have the bend of the shank at the CEJ, you're about as deep as you need to be. So that's a good estimation. And then we finish the sharp dissection with the modified Orban knife. And the reason for that, again, is we might have missed a fiber attachment in a spot or two, and that would block passage of the graft. So we can drop into that sulcus, but careful with this blade because it's longer. So you want to drop all the way to the bend of the shank. And you have to be aware that if you're in the lower second premolar area, as we are here, you need to keep the bend of the shank near the CEJ, and so you're really close to cutting that margin. So this is a little bit of a delicate area to dissect. Draw that blade out slowly. And really pretty much every place else, it's not so critical about that 15 millimeters, but at the second premolar, you want to be particularly careful. So we have completed everything except the separation of the papilla from the crest. And to do that, again, I realize I'm coming in through the throat, but it's the same principle. You want the flat blade of the curette against the root. So this end of the instrument, in the direction I'm coming in, is the correct end. If you use the other end, you'd have to turn the instrument into an uncomfortable position, an impossible position to get the blade flat against the root surface. So that would be wrong. You know it's wrong. And if you have the blade at an angle, that's wrong. You want the blade flat against the root, and you will go all the way till you touch bone. You're into the sulcus of that molar. Go all the way till you touch bone, of course, over to the lingual. Then turn the curette to touch the premolar and course under the tissue back to the facial. So I'll show you on the surface. If I'm going around, is that showing? To the lingual, turn the tip of that instrument to touch the premolar, push down against bone, and come back to the facial. So I want to show you this in a little different fashion. I want to pull a tooth. This was an atraumatic extraction. And now you can see the papilla, I hope. And I'm going to go into the sulcus, of course, over to the lingual. I've already freed it, so it was pretty easy. Then I will turn this to touch the other tooth. I don't know if you can see that coming under there because the tissue is moving. And of course, back to the facial. Try that again. Of course, over to the lingual. So now I've curved around it very nicely. I think you can see that, different views. Then I turn that instrument, and I can't quite, well, you can see it down lower. Not sure you saw it up high. You see it there now. and come back. You're pressing against bone, coursing back to the facial. So I hope that is reasonably clear. If it's not, we will help you individually. There are several of us circulating to help you with that, but I'll show you once more with the teeth in place. So the teeth may move a little bit, but of course into the sulcus, go to the lingual, turn the tip of the curette to touch the premolar, and then press against the bone and come back to the facial. So, all right, you have time to start this now. So you will be doing the 2 teeth, the dissection similar to what I showed you. If you have problems, actually we didn't do this. You can do this any way you like. I'll see that now. But, so this is the graft after we've already taken a little section out. But you can divide it straight down the middle if you want with just one move. And I usually do that with a 15 blade. You can do it as you like. But if I start at one end and just kind of go straight down, and it's a little harder because it's missing. And you can just draw that blade through it, and it could separate it that way. So you have 2 long pieces, and then you can cut this the length that you need. So you measure, I'll put that someplace safe, the size graft that you will need. And if we look at this model, we want the graft to extend completely under the papilla mesial to the second premolar and distal to the first molar. So I'm measuring this probe that I have, and yours might be different. This is a 36811 probe. Yours could be some other measurements, so check it. So I'm measuring 11 millimeters here, and that's 22 millimeters to the middle of the papilla more or less. So I need about 28, possibly 29, and what do you? No, I just need the blade again. So I just do this measurement to see. So if I'm going to do 29, that is 11. That's 22, I think it'll work. That's 22. And I said 29, so that would be 7 more. So that is, there's the 8, so there's 7. So I'm going to cut about here. And that should be the length I need. If it's not, I'll have to borrow somebody's extra length. You may be right. Okay. So I struggle with a doll. So this, we'll check this length, and if it's not accurate, we can change it. It's better to have too much than not enough. So we'll lay this graft on the surface. And that looks like that's going to be pretty good. So a touch of extra length is okay, because sometimes there's a little bit of a dip in between the teeth, and you don't want to have a graft that's too short. So I think this one's going to work. So I'm going to put it back in its solution for a moment. And then I'm going to moisten the model. So you'll do the same thing, just use the water to moisten it. You don't have to do this in the mouth, obviously, because your mouth is moist. But it's hard to insert this graft on a dry model. So just moisten it. And I have the graft very moist. And it's easier to insert the graft through the largest opening, and that will be the molar. So I'm going to check that with the curette. Just see if I get a good preparation here. So I think we can slip that margin under. So if you'll insert one margin, one corner, and you help me out there. Shannon's going to help me with her instrument. We don't have 2 curettes, so she's using an in-cutting knife. But the easiest way to insert it is with a curette. So I got both corners under, and now I just want to start the graft insertion. And you can see it wants to turn and go in vertically. That's just natural because the opening is a horizontal opening, and the graft is going to have to turn to fit into it. So we'll work our way in there a ways. At some point, we can turn that graft a little bit. I'm gonna turn this around so it's more entering from the mouth, where it would make more sense. And I can go into this sulcus and find that graft and pull it and help align it. I'm bringing it under the papilla mesial to that premolar. Now I can continue to insert it. And eventually place it under the papilla distal to that molar. And if you've elevated the papilla, that's easier to do. Pardon me. So we should have the graft pretty well aligned. And it's positioned right now at the level of the CEJ. Pardon me. So I want you to do that. And after you have inserted your graft, take a break. And when everybody has their graft inserted, we'll have a break, just a short break. Then we'll demonstrate the suturing. So when you prepare for the suturing, you're going to insert the graft so it's level with the tissue margin. So we'll review that at the time we suture. So go ahead and insert your graft if you're ready for that. If you haven't finished the site prep, continue that. And once you have your graft in place, we'll demonstrate the suturing. So we left off with the insertion of the graft and left it at the level of the CEJ. And we want to bodily insert that so that the tissue margin is level with the margin, I should say, of the graft is level with the tissue margin. Now, I usually compress that with my finger in the mouth just to align it. Don't just push the edge down, but make sure that the graft is moved bodily into the tunnel. And then we're going to engage the overlying tissue and the graft together. Shannon is going to keep this from migrating out because the graft really wants to, when you contact it with the needle, it's going to want to migrate out the sulcus. So you want to grab the needle in the middle and penetrate perpendicular to the surface. And we're going to be at the distal root 9 angle to start. Penetrate 4 millimeters off the margin through the overlying tissue and the graft. And let me see just a minute, maybe that just a little. And try to bring that needle out without contacting the root surface. I think it did that. And then, is that showing? I can't tell you. If you have to grab that by the point, just grab it gently and then you get a grip past the point. It's really, that needle doesn't want to come out. It's happy there. Okay, so draw the suture in. This is a really long suture for 2 teeth. But you don't want to lose the tail, so be careful about that. And now we'll go through the embrasure. And pass back to the facial through, oh, we have loose teeth here. Sorry about these loose teeth. We didn't get them. This patient's had orthodontic treatment and no retainer. What's that? Yeah, oh, it's an open contact on top of that. Okay, you'll encounter this when you have an open contact. You have a little bit more difficult time suturing. You just have to get please. You just pass that suture through the contact, hopefully. And there we are. So now we're back to the facial. Did you see all that? I can't tell if we're keeping that in view. Trying to. And we want to pass the needle under the papilla. Can you pull that suture out? Shannon's pulling that suture out of the way for me. And I'll pass under the papilla very easily to reach the next tooth, because we want to engage the distal root line angle of the next tooth. And we'll engage again 4 millimeters off the margin at the root line angle. And can you help me with guiding that graft? And pull the suture this way, yeah, good. So engage 4 millimeters off the margin at the mesial root line angle. And you need to have your assistant hold that graft in place because it will want to come out. And try not to contact the suture with the side of the needle because it can cut it. And then you need to kind of snug this up as you go, so you just push the apical border and snug it up a little bit. And then, of course, we have the same issue with the contact. So I'm going to floss it through, or just pass it through the occlusal. I can. Not sure you'll see this. But that will happen in real life. Sometimes there's open contacts. Open contacts make it more difficult because the suture tends to come out. And it can absolutely end up on top of the tooth on the occlusal surface, and you won't notice it until you finished and you see a little blue line going over across the horizontally across the occlusal surface. It's not good. So our next suture is the mesial of the second tooth. We don't need to go under a papilla now because we're going to return to our starting point. We got the distal of the molar and then the distal of the premolar going under the papilla, and now we will engage at the mesial root line angle of the premolar. And I have to get a grip on that needle, bring it out. And you'd like these penetrations to be 3 to 4 millimeters apart, and you'd like for this suture to reside in the sulcus, not on top of the papilla. And right now it looks like I might be on top of that papilla, but we'll fix that in a moment. So pass back through the embrasure, and we'll work our way back to the facial. I may see a problem in a moment. So I like to use a dull instrument to reinsert that in the sulcus, reposition it there as much as I can. There are my loops. And then we'll nudge that up gently. Now you can pass through that opening and you can hold that off. So we pass back to the facial, pass under the papilla to get to the mesial of the molar, and then we go around the molar and tie. feel your way through there. And draw that suture under the patella to reach the mesial of the molar. That will penetrate at the mesial root right angle about 4 millimeters off the margin. And Shannon's holding that graft again because it really wants to walk out. That's a tough graft. These xenografts are really tough, and somebody asked in the last workshop if you can harm the graft inserting it with the curette. Can you grab that in before it falls back? Thank you. And the answer is no. It has great tensile strength, and you won't injure it. You won't injure it with the curette and inserting it. Okay, so we can do that contact again. I think we're through it. There we are. Yeah, that's tricky. We unscrewed these teeth in order to show you the elevation of the papilla, and so they're a little mobile in doing this suturing. So now we pass the needle back to the facial. Shannon picks it up. It's a little easier pass. And we'll keep that molar
From coming out.
and keep it in position. And can you trim that for me, this? Really kind of away from the curve. Sometimes you leave the tail pretty long on the other side of the needle holder, please. And thank you. And so we just trim it so you can see your suture. Do 3 throws in the mouth. On the model, I'm going to do 4. So it's 1, 2, 3, 4, because this artificial gum is more difficult to advance, and it can shrink back and tie it gently so that you don't break the suture. And then you'll do your locking loop counterclockwise, and then one more clockwise. I'm not sure you have to do that one, but and then trim it with a tail that is 6 millimeters long. And that is the finished suturing. So ideally, you can see that this one suture should be in the sulcus. It's a little hard to do that on the model sometimes, but ideally that should ride in the sulcus, not on top of the papilla. The separation here should be at least 3 millimeters. It looks like it is. And this one will be a little bit wider. This one's about 6 because the molar's a bigger tooth. But that is the continuous zinc suture, and you can go ahead and perform that procedure on your models.